He is a board-certified orthopedic surgeon. He specializes in cellular and anti-aging therapies in regenerative medicine, and he's been doing that for over 20 years. The college and medical school training were obtained at Georgetown University, and Dr. Purita has featured extensively throughout the world on a variety of topics, and was the inaugural president of the American Academy of Board of Regenerative Medicine. He's also the medical director, with interests including aviation, that I didn't know, shamanism, okay, fine, meditation, consciousness research, and Ferrari cars. So you can see he's a very eclectic type of individual, so I want you guys to give Dr. Purita a warm hand.
All right, anyway, my name is Joe Purita, and it's an honor to be here. I really thank Dr. Schnellenberger for inviting me. And it's interesting, you're saying, wait a minute, we have a meeting here on ozone, oxygen, and this character is talking about intermittent hypoxia. But interestingly enough, what I'm going to say in my lecture today was kind of mirrored in what Dr. Schnellenberger said this morning. A lot of the pathways are very similar, so stay tuned and we'll kind of talk about it. So let's get started. So basically what I want to do is I want to first talk about mitochondria. You know, any meeting on ozone needs to talk about mitochondria, because when all's said and done, I tell patients in my practice, everything kind of funnels down to the health of the mitochondria. That's what we're really looking at. So we can take a little view. Here's some anatomy here, and you know, we've got to do some of this boring stuff here and there, but you can see some of the various parts of the mitochondria. Let's move on. Okay, so there's some metabolic reactions that occur in the mitochondria. It gets rid of some of the epinephrine, it helps with fatty acids, oxidative phosphorylation, etc., things like that. Okay, so let's look at mitochondrial DNA. Now remember, you get your mitochondrial DNA from your mother. Okay, it's a lot different than the regular DNA in the body. And it's really not that big. There's only 16,000 or so base pairs. And basically these DNA from the mitochondria are a lot different than the regular DNA. And you can see the difference here. When you look at that, look at what we have here. If this wants to work for me, maybe not. Okay, there we go. So look at the nuclear, 3 billion base pairs, 16,000. And mitochondrial DNA is round. And I'm not sure why nature made it that way, but that's one of the things it is. That's one of the little quirks there. Okay, so basically, we see a lot of these pathways. Now, pathways are something that's important. You know, I tell my patients, think of your organs and your cells as the computer hardware, and the pathways are the computer software. And what are we trying to do in regenerative medicine? Just like when we have a problem with our computer, we're resetting our software, we're resetting these pathways. And for instance, you have AMPK pathway, insulin, IGF-1, mTOR signaling pathways. How those are affected really can determine your overall health. Okay, another thing, when I got out of med school or something, I said, oh, this electron transport chain, I'm never going to need that again. Well, was I wrong? Because really, so many diseases and things are related to this electron transport chain. And you can see here, for instance, here we are right here. Another really passion of mine is photobiomodulation. I'm giving a big talk next month on that. And we can see here where methylene blue, what does it do? Cytochrome C oxidase in the electron transport chain. And it's activated by 660 nanometer wavelength of light. So you can see the importance there. But now we can see some things here. Neurodegenerative diseases, look where they start getting affected in various aspects of the electron transport chain. So what we thought was very esoteric and just for those PhD guys, no, it really makes a lot of difference and makes a lot of sense for us in real medicine. And another thing that's a kind of a passion of mine, heat shock proteins. And I'm going to talk a little bit about that later. How a protein folds in a cell can make all the difference in the world. Okay, so the sirtuins, when we're talking about mitochondria, we're talking about oxygen utilization, et cetera, we need to talk about these sirtuins. They're basically a type of protein deacetylases. They remove acetyl groups, okay, great. But they basically help regulate gene expression and they help keep our stability in the genes, more or less. And you can see here, some of them are located in the mitochondria, Some of them are located in the cytoplasm. Some of them are in both areas, but they all have distinct things. So here we are here. Here's some of the various jobs of the sirtuins. Okay, basically insulin secretions, ketone bodies, oxidative stress, cellular respiration, on and on and on I can go. Listen, we could have we could have a whole meeting just on the sirtuins, and it's important. And you can see some more functions of the sirtuins, what they do here. Cell cycle checkpoint, cell fate control, DNA repair, so important as we age. That's really what gives us a lot of trouble. Our DNA becomes damaged. Next thing you know, we start getting cancers. Other things, and I know we're going to have a speaker later on today, but the sirtuins are very intimately involved with DNA methylation patterns and their regulation. And by the way, if anybody wants my slides, I'm more than happy to send them to you. Don't go crazy trying to write down little notes and this and that. Just try and sit back and try and, get what you can, but we'll send you the slides. It's not a problem for us, okay? So basically, they have an intimate connection to the mitochondria. The sirtuins and the mitochondria are like this. They go hand in hand with each other. And they also affect mitophagy, which is basically the selective removal of damaged or dysfunctional mitochondria that's a type of autophagy, okay? And they basically can get stimulated by various factors. Caloric restrictions, basically intermittent fasting, resveratrol, terstilbin. I like terstilbin better, a little more bioavailable. Exercise, NAD, obviously we know that, intermittent fasting and oxidative stress. And just to kind of go back to our basics, what's a free radical? We kind of talk about oxidative stress, this and that. Well, there it is there. Basically, it's an unpaired electron. An antioxidant gives that electron a mate, so to speak. And there we are there, antioxidant balanced, and now we have an oxidant. Now, what is NAD used for? Well, a lot of different things. It's a neurotransmitter, helps with our telomeres, we think, DNA repair, longevity mechanisms, energy production, on and on and on. We probably only know maybe 1/10 of what they really do in the body, okay? But this is some ways that the body can use NAD. For energy production, we know that, obviously. Cellular respiration, redox reactions, DNA repair. If you look at the charts on NAD, every 20 years of life, our NAD level goes down 50%. That's why I'm a big believer, as is Dr. Sinclair, in taking NAD either intravenously, by mouth, whatever. I do both, okay? So important because it helps with so many different things. And here are some other ways of boosting your NAD. And here, just to kind of give you some idea, this is how NAD is made in the body. These are various pathways. This I wouldn't get too concerned about, just to kind of give you an idea. Again, another thing, there's a salvage pathway, and sometimes these steps get sacrificed. And, NAD is intimately involved in repair. And for instance, you have over here the CD38s, kind of a cell marker, but they are very big consumers of NAD. And that's why as we get older, we can't keep up with the damage unless we keep feeding our bodies NAD. Now, what is ATP? Well, it's the body's energy currency. It's really an important thing. But remember now, it's not like a capacitor. It doesn't store energy. Basically, it's not a long-term energy storage molecule. It's more for short-term. And basically, a phosphate group breaks off, and lo and behold, we have energy that it supplies to us. Now, how about glycolysis versus oxidative phosphorylation? Glycolysis occurs in the cytoplasm. Basically, it's an anaerobic process, doesn't require oxygen. A lot of the stem cells love to use that as a way to make energy because basically they don't need much energy. They're very quiescent cells. But as we start heading to differentiate, lo and behold, we have to then start going to oxidative phosphorylation. So you can see there's a big difference in the amount of ATP, 2 versus 36. And there we are there. So a differentiated cell uses energy. A pluripotent cell, same thing, but they can get by with a much less amount of energy, okay? Now, basically, ATP is not just for energy, though. It's used for transport of things. It's used for muscle contractions. It's used for biosynthesis of other molecules, for cell singling and things like that. So it's not just energy itself, okay? Now, one of the things I really involved with is cell therapies. Now, one of the ways probably when we use cell therapy that the cells are really achieving some things are basically transferring mitochondria from one cell to a diseased cell. Because, when we put stem cells in the body, they don't last very long at all. Most of them are there a couple of days, and they get apoptosis and things like that, and they're gone. Some of them turn into Treg cells and things like that, but some of them transfer their mitochondria and make those disease cells healthier, okay? So we have the process of mitochondrial fission and mitochondrial fusion. Fission is usually something we want for longevity, okay? Fusion seems to be involved in longevity, but not always. You really kind of have to have a balance. Like a lot of things in life, there's always a balance between fission and fusion. Okay, and then we talked a little bit about mitophagy, which is the selective degradation of various mitochondria. Most diseases, that's what you really want to get. You're not getting good mitophagy, and that's what happens. And then here's some more things. It's essential to maintain your health, having mitophagy. And another little slide on it that just kind of shows the various aspects of mitophagy. And if the mitochondria is not worth saving, the body will basically recycle some of its parts and move on. And this is one of my go-to supplements, urolithin A, okay? Very, very good supplement. It really stimulates mitophagy. The literature's overwhelming on it, so it's one of my go-to guys, definitely. Every day, every morning. This morning when I got up, took some urolithin A. It comes from the pomegranate, but you can't get it from getting pomegranate because it's kind of like a postbiotic. It has to be produced in a special way, and I'm more than happy to talk to people about it later on. All right, so moving on a little bit. Let's get to the meat, so to speak. Intermittent hypoxia therapy. Again, I said intermittent hypoxia therapy, not just hypoxia. Hypoxia is bad for you. Cancers, hypoxia, things like that. So, not a thing. So basically, it's a new, old, disruptive technology, okay? And you can see some of the things that it does here, low oxygen exposure, et cetera. But let's move on. It's really important when all of a sudden a Nobel Prize is awarded in 2019 for how cells sense oxygen. So important, okay? And important enough to win a Nobel Prize. Now, how is intermittent hypoxia therapy and ozone therapy similar? Oh my God, it's just amazing. I mean, I could just name, if you didn't know it, you would think that I was talking about ozone therapy because it basically treats oxidative stress. It modulates it. It's very dependent upon the hormonic response. The hormesis is so important. And it does immune system modulation, okay? Dr. Snellenberg was talking so much about it, how, the immune system. Remember, the immune system, stem cells, et cetera, they're all intimately related to each other. All right, so basically, again, oxidative stress response. Hypoxia-inducible factors. When we're doing intermittent hypoxia, we're targeting this pathway, okay? And it stabilizes it, and blood ozone dialysis activates the same pathway. Nitric oxide signaling, another very important thing, and yet ozone, intermittent hypoxia, the same thing. Anti-inflammatory and immune modulatory effects, same thing. So you can see there's so many similarities between these two therapies, yet they're really different. So it's really, really something good, okay? So basically, the science of intermittent hypoxia basically is the narrow range of oxygen. It's like anything else. It's too much, too little is going to do some problems for you. So, interesting thing, the bowhead whale, okay? I think that's the mascot for longevity, okay? So there's bowhead whales in the ocean today that were alive before our Declaration of Independence was signed. Think about that. That's a long time ago. And they're still alive, these whales, okay? And why is that? Two things. They practice intermittent fasting because basically they live in the real north cold waters, not that much food. And they, take a breath of air and then they go down and they sound. They're practicing intermittent hypoxia. Both of which we know are very powerful stimulators of mitophagy and mitogenesis, mitochondrial genesis. Very, very important things, but we can take that a step further. Look at some interesting facts about hypoxia therapy. When we develop in our mothers, the PO2 in our environment is the same as that of about 16 or 18 to 19,000 feet. The people in the Huns Valley, basically, they live to about 120 years, some of them, because they're at an elevation of 8,000 feet. So you can see hypoxia in the right circumstances is a very good thing for you. Okay, so basically intermittent hypoxia training, like a lot of the things we do in regenerative medicine, This was started in the former Soviet Union in the 1930s. You know, that's why we used to see years ago, you'd see the Olympics. Russia would be number 1, East Germany would be number 2, United States would be number 3 in the Olympics, because they had, you know, regenerative medicine and things like that down to a science. So you can see why that is. All right, so basically exercise and altitude training has been the traditional gold standard of intermittent hypoxia therapy. And you can see that from this slide right here. You can see what happens, and it makes all the sense in the world. I tell people, I said, look, think of a really good athlete. What's he do? He goes to Denver sometimes to train. Why? Because it's basically a mile high. So he's doing some hypoxia training, okay? Now, you know, we have to always be aware of what's legal and what's not legal. You know, Lance Armstrong got into trouble because he basically blood doped. And I'll get into that shortly. But if you go ahead and do hypoxia training, nothing the WADA can do. WADA is World Anti-Doping Agency. So that's basically what goes on there. So look at the differences now. Now, this is an important slide. Chronic hypoxia on one side, intermittent on the other, okay? Totally different. One causes inflammation. One suppresses it, okay? One increases our glucose, one decreases it, increases blood pressure, so on and on and on. You know, on the hypoxia chronic, you can see all the bad things that cause us bad health, and the other way around. Okay, so chronic versus intermittent, okay? So chronic hypoxia is a hallmark of many pathologic conditions such as cancer, things like that. Sleep apnea is another good form of chronic hypoxia, okay? So intermittent hypoxia is up and down, much different, okay? Now you can see here's what we call the hormesis effect, okay? So we can see here that if you have normoxia, which is kind of sea level oxygen, yeah, not much happens, okay? Moderate hypoxia, still not gonna get much, but when we start going over here, see if I can get my pointer to work, we start getting the benefits. This is one of the most important aspects in all medicine, the hormesis effect. We can see it here, okay? I can take it one step further and I can say, look at what happens when we use ozone, when we start talking about ozone gamma. You know, we can look at it here. We look at that hormesis effect. Usually it's between 10 and 40 gamma for a lot of different things that we do. You know, less than 10, you're not going to get much of results. More than 40, well, you can go up to 70 even, but that's the real optimum part. So that's the hormesis effect in action, okay? And again, low dose stress will provide future protection. Now, also, when we do intermittent hypoxia, we're pulsing. We're going 9% oxygen. When I do my intermittent hypoxia, I go 9% oxygen, 40%, 9%, 15%, something like that. Pulsing in the biologic world is very important. Be it photomodulation, be it oxygen, whatever you're doing. Pulsing makes a difference. Cells respond better to a pulse than a continuous stress. And then again, this is just a slide that's very complicated. The various signaling pathways. Remember, that's the software. That's the computer software. Okay, so here's a very interesting article. This is a really great article. Think about it. Moderate intermittent hypoxia induces telomerase reverse transcriptase. What does that tell you? It's making the telomeres grow longer. What does that mean? That cell is going back in age. It's getting younger. Whereas intermittent hypoxia, just like from sleep apnea, is causing the opposite. The telomeres are getting shorter. So that's really something, if nothing else, if I stop right now, you say, hey, that's really an important thing. If I can make my patients maybe go back in age, and what are we measuring? We're measuring the immune system, immunosenescence. That's the real key there, okay? Now, so kind of to review a little bit, what's a telomere? That's the end of the DNA. It's basically like the end of a shoelace where you have that cap on it. Remember, every time your cells divide, they lose a little snippet of DNA. My cells this morning were longer than they are now because, you know, of the ongoing effect. So here's the consequences of short telomeres: cancer, infertility, arthritis, CNN problems, etc. So there you are. Now, here's where TERP can help. Basically, it restores telomere length. And you can see when you get that, you get all sorts of things. Now, you know, reverse transcriptase, I mean, the problem with that is some cancer cells like to do that too. That's why some cancer cells are immortal. They never die because they keep making telomerase. But telomerase is a very important thing, and we're going to hear more about that as time goes on, okay? So basically, hypoxia-inducible factors. Okay, these are basically a balancing act between oxygen demand and oxygen supply. All right, so basically you can see here, there's basically 3 types, HIF 1, 2, and 3, okay? 1 is probably the most important of these. These are transcription factors. They're stimulated by low levels of oxygen, okay? Now, let's get into some of the nitty-gritty. What's a transcription factor? Well, it basically goes to the nucleus and gets a hold of some genes and says, hey, I want you to make these products. So it gives the genes direction of what to do. Most of our pathways eventually end up stimulating these transcription factors. And you can see it here. We have some activators, we have repressors, and the binding sites. So basically, a gene can only be expressed if the activators are present and the repressor is absent. So this is the field of epigenetics. And that's what we're really trying to stimulate. Epigenetics is going to be where it's at. That's where we're going to make the biggest, I think, improvements in regenerative medicine by learning to stimulate certain genes and put them on and off at the same time. And again, just a little slide about the different types of RNA. There's messenger RNA, there's microRNA, tRNA. I mean, these are all kinds of things. And again, just a slide that you can look at your leisure, just to kind of give you a little bit of information about this. Okay, so here we see a very good slide. It shows you how kind of things work here. So we can see normoxia here, okay? See if I can get my pointer to maybe work. There we are, so, well, it worked a little bit. So you can see up here where it says normoxia. What happens is that hypoxia-inducible factor is bound by oxygen. Oxygen disables it. So it makes it goes on, the transcription is repressed, and what happens is the protein is dissolved, is degenerated, and the peptides are released. However, if we now have some hypoxia, okay, which we have here, all of a sudden that factor can now escape the cytoplasm and go into the nucleus. And once it gets into the nucleus, it forms hypoxia response elements. And it does all sorts of interesting things, like increases blood supply, increases metabolism, increases angiogenesis, etc. So now you start seeing these transcription factors at work. It basically goes from the cytoplasm into the nucleus. That's what the real importance is. Okay, so we can see it here. It's out in the cytoplasm, not doing much of anything, probably going to get disabled by oxygen, unless that oxygen is low enough. Then it gets in the nucleus and does its work. And you can see the various things here from hypoxia-inducible factors. What does it do? Well, it does so many different things, and this is just a part of them, of what it does. But basically, it helps get more oxygen to the cells, okay, when all's said and done. Now, erythropoietin, I used to think, that was, something just makes some red blood cells. This is what got Lance Armstrong in trouble. He was basically injecting himself with erythropoietin, and lo and behold, he got caught, blood doped, and, next was a scandal. But if you use intermittent hypoxia therapy, no problem there. But look at all the things that erythropoietin can do, okay? It affects the brain. The endothelium, there's something called the glycocalyx, which you guys are going to hear a lot more about as time goes on, how basically it's a nice smooth covering in all the vessels. And that's when that gets damaged, you start having problems. So it also affects white fat, bone remodeling, myoblast, the heart, all sorts of things that this is involved with. And stem cells, okay? One of my passions, obviously. And you can see erythropoietin basically is hematopoietic stem cells, non-hematopoietic, the MSCs and things like that. So that's where it really is an important thing. And the hypoxia-inducible factors basically stimulate it. And you can see right here, you don't have to worry about WADA with this right now. What's WADA going to do? Say you can't train? No, not going to do that. Now, it also induces VEGF, vascular endothelial growth factor, okay? There's a couple of different types of VEGF, but VEGF is very important in the world of regenerative medicine. It helps build blood supply, and that's the important thing, and it helps vasodilation and things like that. Now, I want to show you one slide here, because a lot of people take angiogenesis and vasculogenesis, they think it's the same thing. It's not, much, much different. So angiogenesis is where you're building vessels where you already have some to begin with. Whereas vasculogenesis, you need to build new vessels where there aren't any. That's why a PRP, for instance, will work well in a tendon or a muscle injury because there's already a blood supply there. And it just has to supply VEGF. Whereas a stem cell is needed for SDF1, stem cell-derived factor 1, in a joint and things like that. That's why PRP alone in a joint, probably not going to help it. Give it some hypoxia, it may help it a little bit more, but you need the stem cells there. Now, Hemoxygenase 1. Dr. Schellenberger mentioned that this morning. Very important, enzyme, transcription factor, et cetera, et cetera. And what it does, it helps our macrophages. When you get stimulation of this thing, let me try and go back here. Okay, so when you get stimulation of this, it starts affecting something called the macrophages, which are sort of like in the form of white blood cells. But not all white blood cells are the same. You have a macrophage 1, which is great when you have an infection, you have a COVID, God forbid, or something like that. It gets into play and really does its work. It kind of attacks things. But there's also a macrophage 2, which actually causes cell regeneration. And hemoxygenase 1 actually makes a polarization. It goes from a macrophage 1 to a macrophage 2. So it helps regenerate the tissue. All of a sudden you say, wait a minute now. Now I start seeing how hypoxia actually is good to help regenerate tissue because it's affecting our immune system. Everything comes down to immune system also. How you affect the immune system is how you're going to affect your results. Okay, so again, we can see here in the brain. Okay, now a microglia is essentially a macrophage in the brain. And you can see here when you have moderate intermittent hypoxia, it basically gives you a surveillance microglia and it gives you growth factors and basically is very beneficial. Whereas when you have chronic hypoxia, it's inflammation, phagocytosis, loss of plasticity, and problems. All right, hemoxygenase 1, what else does it do? Well, it's a very interesting compound because it can basically break things down and produce some very strong anti-inflammatory agents. It can produce something called ferritin, which is an antioxidant, biliverdin and bilirubin, which are important antioxidants. But here's a very interesting thing. It produces carbon monoxide. You can't survive without carbon monoxide in your body. Okay? Carbon monoxide is a very important gaseous singling molecule. 3 gaseous singling molecules: nitric oxide, hydrogen sulfide, and carbon monoxide. And Dr. Schellenberger hit it on the head this morning. He says, nothing's really toxic. It's the concentration of things that are toxic. Here we are with nitric. We know that carbon monoxide is deadly in a certain concentration, but in a very small concentration, extremely important, a very important singling molecule, and reduces inflammation. Again, reducing inflammation, going to give you better success in achieving regeneration. And again, you can see some of the various aspects of hypoxia-inducible factors. Blocks inflammation, blocks vascular disease, cancer, etc., and some good things there. Okay, now heat shock proteins. Hypoxia is a stress. Ozone is a stress. When I gave electron ozone, same thing. I said, hey, one of the things it produces is heat shock proteins. Basically, these proteins make the cells, or the proteins fold in the cells properly. Many of the conditions we see nowadays, you have a patient who's not responsive to testosterone. It may be that his receptors, the proteins did not fold properly, and that's the problem you're getting. So when you stress things, you're getting something called heat shock proteins. Cold shock proteins also. That's why nowadays contrast therapy is very important, okay? Now, you can see here, we have here, for instance, hypoxia-inducible factors, things like that. It goes in there, and it produces heat shock proteins. And there's a whole host of them. There's heat shock protein 90, heat shock protein 70. Some of these are good, some of these are bad, because, cancer cells also produce them too, and it helps the cancer cells survive. So, got to be a little, expeditious about some of these heat shock proteins. But here's a little cartoon, but it kind of tells what they do. It kind of analyzes a protein, and it says, you're damaged too much. Sorry, I'm going to just have to get rid of you. Or, yes, I think I can fix you, and we'll go from there, and we'll go on and see if we can make you work again. And again, they're like little chaperones. They basically help the protein fold properly in the cell. Now you can see it here. Here's some heat shock proteins, and it promotes longevity. Most of the time, they're good things for you. Now, here's an interesting thing. Basically, hypoxia-inducible factors stimulate something called P53. That's also called the tumor suppressor gene, okay? Now, we think a lot of cancers are related to a malfunction or lack of this gene. Now, here's an interesting thing. Elephants, which are essentially, other than whales, the largest mammal we know of, almost never get a cancer. Very low rate of cancers. You'd say, wait a minute, they have so many cells, why don't they get cancers? Well, guess what? Elephants have multiple copies of the heat shock protein, of the P53. We have 2, elephants have 40. So now you see the importance. If we can keep that P53 going, I mean, P53 basically analyzes cells. It looks at DNA damage, it either fixes it or it gets rid of it. But when it doesn't work, those cells with the bad DNA accumulate and bad things happen, like cancers and things like that, okay? So, intermittent hypoxia and nitric oxide. Well, again, another important signaling molecule. There's 3 types of nitric oxide: inducible, endothelial, and neural. Now, the inducible one is the one that sometimes can get you in trouble because that can actually be involved in infections. And it's a good thing for that, but not a good thing when you're trying to regenerate things. But basically what we're looking at here is the endothelial type, which goes ahead and basically makes your vessels work better. And as Dr. Schnellenberg was talking this morning from the classic work of Dr. Tom at the University of Pennsylvania, nitric oxide is really how hyperbaric oxygen works, okay? When all is said and done, I have a slide in one of my series. It says, cells, not doctors, heal patients. And the more cells you have, the better chance you have of getting better. I mean, when all is said and done, you have a diabetic with a foot wound, and you give him hyperbaric oxygen, it's not because he's getting more oxygen to that area. That helps, but ultimately his cells have to heal that. And that's why I like to use nitric oxide supplements. There's a number of them out there, and I'm a firm believer that all my patients that get regenerative therapies get that. All my patients that go into hyperbaric oxygen get a nitric oxide supplement also. And you can see the relationship here between nitric oxide, a very important signaling molecule. Okay, the glycocalyx. Okay, I was telling you about that, and that's something everybody needs to learn more about. I mean, I'm learning about it little by little, and it's an important aspect of health, and it's really coming into its being now. And there are some companies out there that are making products to make this healthier. Look into this, learn about this, and I'm still trying to figure out how ozone's going to affect it, but I suspect ozone's going to have a very beneficial effect on it. And again, you can see here, when the glycocalyx is really damaged, you lose the protection, you get permeability. For instance, the brain barrier, all of the blood-brain barrier, all of a sudden when that barrier starts to leak, bad things happen. Again, the glycocalyx is involved. Okay. Now, stem cells and hypoxia. Well, okay, you can see here, look at all the different things that, hypoxia does for stem cells right in there. We can see that right there. So we go on. Now, the PO2 in your bone marrow is around 20 to 50. Everybody says, oh, no, wait, it should be a little higher because that's blood supply. Nope, it's about 20 to 50. And basically, it helps keep that low oxygen basically keeps these stem cells happy. They don't like room air oxygen or anything like that, okay? And you can see here, intermittent hypoxia benefits stem cell therapy. What do I do, for instance? When I do my stem, and I happen to do a lot of autologous stuff. I do bone marrow, I do fat and everything. Everything gets put basically in low oxygen conditions. I put it in a Vacutainer or something like that to prevent it from really getting exposed to a lot of oxygen. And you can see here, so hypoxia-inducible factor is responsible for the quiescent nature of the stem cells. It keeps them at a very low metabolic rate. Remember earlier in the lecture I said, hey, stem cells like to use glycolysis. They don't need much energy. When they get kind of pushed along to basically differentiate, that's what happens, and they need more energy, okay? So basically, hypoxia keeps the cells from differentiating and going on to various pathways and things like that. It promotes blood vessels and things like that. Very important for chondrocyte survival. Now, this is one of the things that's very dear to me, called a V cell, very small embryonic-like stem cell. And here's a great article. Intermittent hypoxia mobilizes bone marrow-derived small stem cells. These cells are very important because I use them all the time. We take them from the blood, we give them back to the blood, so like to like. There's very little regulatory issues with these cells, and they're autologous, okay? And you can see here, what else do? They reverse immunosenescence from this very classic study. When you reverse immunosenescence, you're making that patient healthier. His immune system is growing younger, okay? And this just tells you a little bit about these cells. They're probably an early CD133. We use 4 degrees centigrade, and we put them in basically a little chamber that is essentially no oxygen in there, and we keep them overnight and give them back to the patient intravenously the next day. So hypoxia, we know, can give survival. Don't Don't bet yourself short. Always do hypoxia when you're doing any therapy. If it's basically, cord blood cells, anything like that, you try and give them hypoxia. It's going to make them stronger. Now, let's get into some of the systemic responses of intermittent hypoxia. You can see here on the various aspects of it, body rate, cell metabolism, we kind of got at cardiovascular and respiratory. So let's kind of get into this a little more, okay? So basically has a pretty significant influence on weight. Those of you that have been skiing, you notice once in a while when you go up to the mountains, you say, I don't have my appetite today. I kind of lost it. Well, that's the anoxia. Well, that's basically you're not really from the anoxia, so to speak. You're not that appetite because basically certain compounds are stimulated in your body. So you can see some of the metabolic effects observed. You'll lose weight. It suppresses your appetite, decreases cholesterol, decreases blood glucose, etc. So some of the things here. So you can see here, it can affect the lipid profile. So probably a good thing for diabetics, among other things. It really is a good treatment, and it's easy. You have the patient sitting in a chair, essentially breathing in different levels of oxygen, okay? Now, also it regulates the glucose sensing in the central nervous system, which is extremely important. We start getting into some really kind of esoteric but yet important things, hypothalamic glucose sensing, okay? And leptin, and I saw it on one of the slides this morning somewhere. Leptin is very important, and this basically is what helps us with our food intake and our, feeling satisfied when we eat and things like that. And the problem's going to happen is what happens is when patients are going on the semaglutides, when they get off of these things, their leptin's going to go crazy, and that's the problem these people are going to run into, okay? So you can see here that, hypoxia basically can stimulate and regulate leptin and insulin, basically makes us more sensitive to it, and that's the important thing. It helps suppress and the suppressor of cytokine signaling. Suppressor of cytokine signaling is so important in so many different things, so many different ways. And, it has one of the other main pathways, the NF-kappa beta pathway, which is the major pathway of inflammation, whereas NRF2 is the major pathway of anti-inflammation. So that's important. You can see here some of the signaling targets. Again, just something for you to look at. And this is, again, kind of a technical slide, some of the pathways that are involved with this. But again, the semaglutides. I've had some people in my office, they go off the semaglutides, a couple of my nurses, and they said, oh, man, now I'm really hungry. So I gave them some intermittent hypoxia and put them on some low-dose naltrexone and a couple of supplements. It really helped them dramatically. So something to keep in mind, and it's a very practical thing for us to do. Another thing that intermittent hypoxia stimulates, AMPK pathway, and basically also the GLUT4 pathways. And let me tell you something, it can really make a difference sometimes. And we see this sometimes when we do ozone in our office. We'll see that blood glucose drop dramatically when we do ozone dialysis. I mean, we've had people that we have to give them D50W because of the effect of AMPK, the GLUT4, and blocking mTOR. It really drives that glucose into the cells. Same thing with intermittent hypoxia, not much different at all. So let's get some of the practical aspects. There's localized hypoxia and systemic, okay? So, blood flow restriction, something each and every one of you can do in your office. You can buy these cuffs online, and you can start doing blood flow restriction, okay? What it is basically you're exercising with tourniquets that can sense what the blood pressure is, and then it can just allow a certain amount of blood to go through. So you're causing some intermittent hypoxia, you're causing some increase of lactic acid, things like that. But what it's doing is it's stimulating a number of different pathways. And it seems to be very good for a lot of different things. But look at this slide. This is a very telling slide. You have somebody who, let's say, is really in a lot of pain. They can't exercise that well. They can't do high-intensity exercises. Well, try and look at this slide and look at the difference between the high-intensity exercising and low-intensity exercising with blood flow restriction. Look at, for instance, the amount of IGF-1. You have an increase, but you have a significant increase here. Okay, growth hormone, 100-fold increase with low intensity with blood flow, 1.7 times greater than high intensity. You also have a myostatin blocker. That's the holy grail of bodybuilders. So now you start seeing, hey, blood flow restriction's a really interesting thing, and it really works. That's the good thing, and it's cheap. So what a great combination of things. So really a good thing. And you can see here basically what happens, some of the various pathways again, growth hormone and things like that. So it can really make a good difference. And it also affects the myokines, which are basically growth factors secreted in the muscle. You know, the muscle's probably one of the most important organs in the body because, you know, a sound body, sound mind, and it's making a lot of these various growth factors like brain-derived neurotrophic factor, things like that, which can really make a big difference in neurodegenerative diseases. So that's why, see, a lot of these neurodegenerative people have trouble exercising. This can maybe help them. Okay, so there we are there, some of the aspects there. Now we can also do systemic hypoxia. Basically, we do it with a machine, but you know, you can try and do it with other things also. You can even hold your breath, in all honesty. The machine I happen to use, it goes between 9 and 40% oxygen. And you just basically sit there. I can listen to a radio, watch TV, kind of fall asleep. And the sessions can run 10 minutes to 90 minutes, and they're tailored to the patient, okay? And, you know, typically we go maybe a half hour with a lot of these things. And there's basically a lot of things that this systemic intermittent hypoxia can help. Asthma and bronchitis, chronic heart and lung diseases. You would say the opposite. You'd say, no, it can't help that. Well, yeah, it does, okay? Because, again, ultimately it's helping the mitochondria, okay? Now, these are some of the contraindications, and I think as time goes on, we're going to see that a lot of these really are not contraindications. I'm just kind of giving you the whole scoop, so to speak. But here we are here. These are some other ways that you can do it without an expensive machine. I mean, some of these things I'm not even sure about, some of the methods down there. But I'm sure some of you guys may know them, and they probably work and work well. So here's the machine we happen to use. I think this one comes from Europe somewhere. It's hard to get some of these machines in the United States, but we're working on that now. We think we'll have some avenues to be able to get these in, okay? And you can see here, so you breathe in oxygen, and then you start seeing your PO2 go down. I mean, I've had my PO2 down to in the 70s. You know, normally you'd say, wait, this guy needs to be intubated. Didn't feel anything. I felt fine, just sitting in the chair. My staff was worried at first. They said, hey, wait, if you croak, we're going to have problems here. But I was fine, you know, because I got used to it. So it just shows you something. And again, there you are there. And so basically, you don't really start getting benefits of the intermittent hypoxia systemic therapy until your PO2 goes below 90. That's when you really start getting the real good values. And like I say, we do it, and I go down, I breathe 9% oxygen, which is about the equivalent, I guess, of about 24,000 feet. Now realize, again, 24,000 feet, the oxygen concentration is still 21%, but the pressure is a lot lower, okay? That's what makes the difference. Now, also, something called the oxygen hemoglobin dissociation curve. You know, it's a lot of stuff there, but here's the thing to really worry about there. Basically, when you do intermittent hypoxia therapy, it shifts it to the left. You increase oxygen affinity, so it kind of decreases the oxygen unloading a little bit, but that's temporary. Whereas when we go to ozone, it's kind of the opposite, where you have a shift to the right, where it's basically, increasing oxygen unloading, decreasing the affinity. So each has its benefits. And this is the regimen we follow. Like I say, I'll go down to 9% and I'll go up to 40%. I keep bumping it up and down, bumping it up and down. And again, you can see here some of the things that you can get. Basically, it gives you protection from a number of different entities, so to speak, okay? Now, this is a very interesting thing. The Israelis taught us something very interesting. The hypoxia-hyperoxia paradox. What the Israelis basically taught us, and it's a very good thing, they said, hey, when you have your patient doing hyperbaric oxygen, basically you should start doing air breaks. So what they would do is they'd have these patients do, and I do it in my office, 15 minutes of regular, now we happen to do it with a mask. I'm not a big believer in the pure oxygen. There's nothing to be gained by that except it's dangerous, okay? So we have the patient breathe in pure oxygen under atmosphere. Then after 15 minutes, okay, take your mask off for 5 minutes. Okay, and lo and behold, they do that, then go back, and we keep bumping it up and down. Now, what the Israelis found is if they did that, they increased the length of the telomeres of the immune system. They reversed immunosenescence. Very important aspect. And this is basically some of the pathways that they're involved with. And you can see here, NRF2, one of our buddies, and things like that. So that's what we're seeing when we start doing this stuff. Okay, so they feel that the fluctuations in free oxygen concentration, rather than the absolute level of oxygen, is interpreted at the cellular level as a lack of oxygen. So even though we're going down to just room air of 20%, the body's sensing otherwise, and that's the important thing. So basically we can see here. So you can do it with normoxia, but we think it's probably better if you do it with higher levels of oxygen, okay? And that's why we use hyperoxia rather than normoxia. It seems to trigger more of the pathways, reactive oxygen species, et cetera. So that's why we end up doing that there. And again, some of the things here, it's a very good way of non-pharmacologically doing good for the patient. It reduces blood glucose levels, blood pressure, improves cardiovascular health, metabolic disease. I mean, you couldn't ask for a medicine. I know of no medicine that can do all these things at once. And that's what's good. And you can do this in older people too. We've had some people very old do it in their upper 80s and things like that. So there you are there. And again, increases telomere length, decreases immunosenescence. Another article from the Israelis again. And again, it comes down to basically, when all is said and done, it increases different growth factors, angiogenesis, mitochondrial biogenesis. I can't say that enough. I keep, like I'm blue in the face, but it's that important, okay? And also it helps with concussion syndromes also. So pretty much there's a lot of material that we've gone over, and I'm more than happy to answer any questions you have. I'm more than happy to send you guys things. I know I went very fast, because I'm used to trying to get this thing done in a half hour, but thank God they gave me an hour. So any questions out there? Yes, sir.
When you're using hyperoxia, you just define a time segment, then come down to normal air, or do you monitor pulse ox, and does that determine when you take off the hyperoxia?
You mean when we're doing it in hyperbaric oxygen?
Well, you just mentioned hyperoxia, so you take it up to like 40%.
Oh, well, in the machine, you tailor it to the patient, okay? I mean, I tailor myself where I'm only going to that 40 oxygen, I'm going that for a minute, and then I'm going down to 9%, okay? But you can tailor it to, and you got to start out slow. It's like anything else, you build up an endurance. Okay, any other questions?
Monitoring pulse ox.
All the time, monitoring my pulse ox. I mean, once in a while I get really scared when I get down to like 75 or 76, I say, but I'm okay, but sometimes I'll take it off and just start breathing too, though. Yeah, question over here. Yes, sir.
What would a treatment regimen look like? How often would you bring them in? How long would you...
Okay, I typically tell patients come in 3 times a week for maybe a month. I have some people do it more. Some people come in before they're going to go skiing. We don't have much snow in South Florida. I'm about 3 hours south of you here. But they'll do it before they go skiing. And people say, oh my God, I went there, I didn't have any shortness of breath, nothing. So it depends on what you're trying to accomplish. There's no harm in doing more of it, okay? It's not like it's going to be too much for you to do. Yes, sir.
The local hypoxia I was talking about, give me the protocol. How do you do that? You're putting those cuffs and stuff.
Okay, so basically I would do it myself. Sometimes I'll go on my elliptical and I'll put them on my thighs. I can do it maybe 10 minutes at the most, and it really starts to bother me a bit. But you can lift weights. I mean, you can start out slow. You can make it so they're hardly restricting your blood flow. It's like anything else. You build up an endurance to it. But they work well, and you can buy them online.
Basically, you're using them as a tourniquet.
It is a tourniquet, not as a tourniquet. It is a tourniquet. You blow it up. It senses your blood pressure, and then it adjusts accordingly.
I mean, those cuffs that you can buy,
You can buy them online. Go to Amazon. You can buy them. I think one place I bought them from is Smart Cuffs.
What do you call them?
Blood flow restriction cuffs. Yeah. Any other questions? Yes, ma'am.
Do you do the same thing? They do that with the EWAT machine, exercise with oxygen? Is that where they deoxygenate you to like 90 and then they go back?
It's probably very similar. I have not used that machine myself, so I would suspect it's probably very similar, but you don't have to necessarily exercise with this. You can just sit in a chair. Some people can't exercise. You can just sit in a chair and take it easy. Yes, ma'am.
Is restriction, does it matter if it's the upper or lower extremities, or it doesn't matter as long as it's restricting blood flow?
Well, your legs may get jealous of your arms if you just do it in the arms, so. No, it doesn't matter one bit. I mean, it's probably better if you do it in your legs if you can only do one, because you have more muscles there, so you're going to get a better effect, okay? Let me get somebody else. Yes, sir.
I do elliptical in the morning, and I kind of hypoventilate. I'll kind of hypoventilate, and then I'll breathe.
Okay.
90% oxygen off and on. Am I doing anything?
You breathe 90%? You mean you just breathe it in?
Yeah, oxygen concentrator.
Okay, that's probably a good thing. I mean, in all honesty, that's a very good thing. I would see you're basically doing what I'm doing. You're basically, probably getting a little lower oxygen and then a little higher oxygen. So you're bumping it around. Good thing. Yeah, I do my elliptical every morning. Yes, ma'am, down there. You know what? My stem cells in this one ear are not the best. Okay, so maybe you can talk a little louder or come up over here.
Yeah, do you know the difference between the cellular oxygenation level and the pulse oximeter? What are we getting at the cellular level?
Well, okay, I think Dr. Stellenberger said it this morning. There's a lot of differences between various aspects in the body. I mean, look, pulse oximeter is basically giving me a kind of a general idea of where I'm going with my oxygen. I just want to look in there in my blood supply, basically. But, certainly in the cells, it's a lot different. It depends on pathologies and things. Yes, ma'am, you had a question.
The machine that you showed, where would you obtain that from?
That one came from Australia.
Okay.
And
is there one available in the U.S.?
There was one company in Texas, but we're, stay tuned. We're working on somebody from Europe. A lot of these machines are in Europe, but they don't want to send it here. They say, oh, well, we can't get through the FDA. I said, guys, just send it as a physical therapy device, and you're going to be fine.
So
not a medical device. I have this company from Australia, the one I have, but, just to get parts is just like, a big hubbub. So, I'm just telling you. Yes, ma'am.
Name of the company?
Bella? What's the name of our company? This is Bella, my head nurse. She saves my rear end all the time.
I'll look it up and I'll get it for you.
It's an interesting company. Yes, ma'am.
Sorry, for chronic patients, if you did this hypoxic thing and then did ozone therapy, would you get better outcomes if you tried that?
When you say ozone therapy, what do you mean?
Like major autoimmunotherapy or you
Why wouldn't you? Okay. No, absolutely, I would think. First of all, when I do, EBO2, I'm basically getting, stimulation of NRF2 pathway. I'm getting rid of toxins and things like that. And then this is just going to basically be able to give more pathways to be involved. So I'm stimulating more pathways. I think it's nothing but good. And we've done that sometimes, too.
So the outcomes would be better than just doing major autoimmune therapies. That's what I'm trying to understand. Would I get better outcomes?
Well, again, you're stimulating a lot of the same pathways.
Okay.
So, sometimes more is better, sometimes more is not. But I think in this case it would be better. Yes, sir.
To get a patient started, how long would you cycle at the 9% and then the 40%?
Again, it depends on, you got to kind of keep an eye on them initially, okay? But, normally I would go like 9% maybe for like 2 minutes, and then I'd go up, whereas me, I go like basically, 9% oxygen for like 10 minutes, and maybe 2 minutes I'll go to 40%, and then I'll go back down. It depends. It's like anything else. You got to get used to it.
In a normal, healthy patient that doesn't have lungs issues, they just doing high-intensity interval training, walking up hills. I mean, those things are all hypoxic-inducing.
Exactly.
Wim Hof, all that is for the normal person.
They are hypoxic-inducing to a degree. You're never breathing less than 21% oxygen, though. That's the problem. You see, you got to get that lower. Your PO2 is probably not getting that much lower. You see, that's the whole key. You're getting lactic acid buildup, which is going to stimulate many of the same pathways, but not all of them. Yes, ma'am.
Highland, 9,000 feet.
Well, if you remember one of my slides, I showed the people from the Hunts Valley, and they lived to 120. So, I'm moving there tomorrow, I guess. I don't know. I mean, basically, it's, they're getting used to it. I mean, if you look at all these studies, that slide really tells a lot. I mean, in Switzerland, people that lived at a higher altitude, or the people in Peru that live at a high altitude, they found no cardiovascular disease at all, zero.
No, but we have cardiovascular disease.
Where?
Quito.
Quito, okay, well, but how high is Quito? I don't know.
9,000 feet.
Okay, well, maybe it's what they're eating. I don't know, there has to be something, but in general, there's always exceptions, but in general, that's what happens. Any other questions? Yes, ma'am.
Can you tell me, please, about the bowhead whale again?
The bowhead whale, okay, so that's a whale that basically lives in the North Sea, or northern seas, I should say, like the Arctic Ocean. Doesn't get much food, and it really kind of goes down and really stays underwater for a long time. So it does intermittent hypoxia, intermittent fasting, basically increases mitogenesis.
And they live a long time?
Well, there were some of them alive, they say, in the ocean that were alive when the Declaration of Independence was signed, and James Monroe was president.
How do they know?
How do they what?
No.
Well, I mean, listen, how do they know? I mean, I don't know. I'm not a marine biologist, but I mean, I imagine if you look it up, seriously, look it up and you'll see the studies. They live up to 260 years. So I did the math. I said, okay. Any other questions? And listen, I'm around here, guys. We've got a booth 20. More than happy. I'll be here until late Saturday. So, I'm more than happy to discuss a lot of different topics, stem cells, photomodulation, whatever. And again, it's been my honor to talk to you guys. Thank you so much.
Dr. Purita, we want to present you with the highly coveted ozone congratulatory certificate.
That's very kind of you. Thank you so much. It's an honor. Thank you. Frank, it's an honor to talk at your meeting. Thank you so much.